Module 7 is about hematologic, immunologic, and neoplastic disorders. So the first thing we're going to talk about is hematological disorders, which are basically blood disorders. So some quick patho about blood disorders. Hematopoiesis is the process through which bone marrow produces blood cells and platelets. So this occurs in the bone marrow for the most part. And then erythropoiesis is the production of red blood cells using erythropoietin and iron. We all know red blood cells increase the patient's hemoglobin and oxygen carrying capacity. The lifespan of a normal red blood cell is 120 days. After 120 days, they are destroyed by phagocytes in the spleen and liver through a process called hemolysis. So when there's some sort of disruption in these processes, that's where hematological disorders can happen. The first hematological disorder we are going to talk about is iron deficiency anemia, which is the most common type of anemia. It occurs when there's not enough healthy RBCs to carry oxygen to the body's tissues. So this condition is a dietary deficiency, more common among infants who are given cow's milk and picky toddlers. On assessment, if we are assessing a child that we think may have iron deficiency anemia, some signs and symptoms we may see are things like irritability, tachycardia, even a murmur, brittle nails, poor muscle tone. Their skin may appear to be porcelain-like. They may also be prone to infection, be edematous, have slow growth, and delayed learning. It is recommended by the American Academy of Pediatrics to screen for iron deficiency anemia at the 12-month checkup. If we were to look at the red blood cells on a slide under a microscope, they would appear small and pale compared to healthy RBCs. And if we were to draw a serum iron, it would be low. And no, you do not need to know the values for those. Intervention-wise, this is a pretty easy fix because we can just give the child iron supplementation. So if we're talking about a baby or a toddler or even a small child, it's going to be a liquid iron. The problem with that is it stains both fabric and tooth enamel. It's also very gross to eat. But we also, of course, have pills for older children. There is IV or even IM in extremely severe cases. We also want to educate on using iron fortified formula or breast milk and to not use cow's milk until at least 12 months of age. If the baby or toddler is eating solid food, we can recommend foods that are high in iron. So things like meat, shellfish, legumes like beans and lentils. There's fortified cereals and dark green or leafy vegetables such as spinach. The next hematological disorder is acquired thrombocytopenia. You can call it ATP for short. Thrombocytopenia means low platelets. So in this disorder, platelet counts decrease because of some sort of causative agent, which is usually an infection, but it could also be drug or chemical exposure. So it could be something like chemotherapy or some sort of hazardous chemical exposure. So once we remove whatever the causative agent is, whether it's an infection or some sort of exposure, then the platelets will recover. So it's not necessarily a permanent condition. Signs and symptoms of this one are spontaneous bleeding. So things like bloody noses, bleeding gums, blood in the stool, bruising easily, petechiae like shown in this picture, or recent known exposure to any sort of infectious agent or chemical. If we test the platelet ranges, there are different ranges for different ages and depending on which text you look at. However, generally speaking, most texts will say anything less than 150,000 is indicative of thrombocytopenia. But anywhere from about 150,000 to 400,000 is expected. Interventions for acquired thrombocytopenia are things like preventing bleeding and monitoring bleeding. So instead of using a hard toothbrush, which are typically given in hospitals, using things like the soft toothettes for oral care. Also monitoring for bleeding in any areas such as stool or urine. Avoiding injections and suctioning. So for example, not giving vaccines at this very moment, holding them till later. Not over suctioning unless it's absolutely needed. So for example, like nasal suctioning. Avoiding aspirin, which isn't used very often anyways. Avoiding injuries as good as they can. And sometimes they are prescribed steroids to increase platelet production. The next disorder is sickle cell disease. So sickle cell disease is the most common genetic condition. It's characterized by either a partial or complete replacement of abnormal hemoglobin S for normal hemoglobin A. So when this happens, the hemoglobin S deforms the cell shape from round into a sickle shape or like a moon shape. So this can cause tissue damage all over the body and other complications, which we will talk about. This is autosomal recessive. So for example, if both parents are carriers, then a child will have a 25% chance of having sickle cell disease. 1 in 13 African Americans are carriers. It's also sometimes termed sickle cell trait, which means that they're a carrier. You don't have to be African American to have sickle cell trait or sickle cell disease. It's just more common in that ethnicity. Some of the signs and symptoms are with a baby, usually they are asymptomatic until about 4 to 6 months of age. When we are born, we're born with fetal hemoglobin, which is another type of hemoglobin. And the sickle hemoglobin and sickle-shaped cells start to replace the fetal hemoglobin sometime around about 5 months of age. So at that time, then the baby could start to show symptoms. Other common symptoms are things like cool hands and feet, dizziness, fatigue, pallor, and shortness of breath. One of the more severe symptoms is what's called a vaso-occlusive crisis. So when this occurs, there is an obstruction of blood flow that's caused by these sickle-shaped cells. So basically, they're shaped in a deformed way, and they more easily clump together and don't flow through the bloodstream as we would normally expect round RBCs to do. So this can lead to things like obstruction of blood flow, tissue hypoxia, and necrosis, which, as you can imagine, can be very, very painful. So sometimes these patients also are diagnosed with chronic pain. Another severe symptom is called acute chest syndrome, where the patient may have chest pain, fever, cough, wheezing, tachypnea, and hypoxia. So if someone with sickle cell disease gets a respiratory infection, like pneumonia or even just like a normal cold, it can turn into acute chest syndrome, which can be very severe and life-threatening. They can also have spleen enlargement. So these sickle-shaped RBCs do not live for the 120 days as normal RBCs do. They live for a much shorter time. So since they are basically going through hemolysis more often than a normal person, the spleen can become enlarged because of basically all the extra work it's doing. Also, there can be vaso-occlusive crises in the actual spleen, so basically obstruction of blood flow through the spleen, which can cause splenomegaly. They can also have obstruction in the brain, which could lead to a CVA or a stroke. They can have delayed growth and sexual maturation. They can have retinopathy in their eye from lack of blood flow, and also dermal ulcers. Testing for sickle cell disease. So the most common test is called the sickle turbidity test, which is a finger stick test that can give you a result in just a matter of minutes. It basically determines whether that hemoglobin S is present or not. Of course, if you can also look at the RBCs under a microscope and see that they are sickle shaped. There's also the newborn screens. But again, like I said before, we do have fetal hemoglobin when we are born. So the sickle cell disease may come up as basically a false negative if it's not seen because of this fetal hemoglobin. Intervention-wise, we always want to apply oxygen, or almost always, when we have somebody coming in to, say, the ER or the hospital in a sickle cell crisis. So the first thing is ABCs. They have these sickle-shaped cells. They're not getting oxygen to their tissues, so we want to apply oxygen first off. Yes, they are usually in intense pain, so that may be our next step is pain management, giving them whatever sort of pain medication or non-pharmacological pain treatments that we can. We may need to do activity and rest cycling, basically meaning letting them rest, having periods of rest, and then having them do periods of activity like walking down the hall. They may need oral and IV hydration. So a common cause of a sickle cell crisis is being dehydrated. So if you can think of having all these sickle-shaped cells floating around the bloodstream and less sort of water in that, it's going to be more easy for them to clump together and cause a vaso-occlusive crisis. So one thing we can educate them about is staying hydrated just on a day-to-day basis. But then if they come into the hospital, they're probably going to have IV fluids running. Also, antibiotic prophylaxis. So it's very common to be on prophylaxis against pneumococcal infection. So basically preventing any sort of lung infection that could then in turn turn into an acute chest crisis. Also, physical therapy may be needed if they're having specific symptoms in their extremities. They could eventually need a splenectomy if it's enlarged for a long period of time. One of sort of like the last resort interventions is a hematopoietic stem cell transplant, also called a bone marrow transplant. Basically, this will replace cells that have this defective gene in it in the bone marrow that's basically making these red blood cells. This can be a very dangerous procedure, which we'll talk more about in a little bit, but it's usually sort of a last resort. You also, of course, need someone to be cross-matched for transplant. There are a lot of support groups and resources that we can refer patients and their families to. And also, they may need genetic counseling if they are planning on having children, basically seeing what is the risk of having a child with either sickle cell trait or sickle cell disease. Aplastic anemia is also called bone marrow aplasia or failure. Basically, this occurs when the patient's bone marrow doesn't make enough red blood cells, white blood cells, and platelets. So damage to these three different blood cell types produced in the bone marrow then causes anemia. So this is a rare but very serious blood condition that occurs when, for whatever reason, the bone marrow can't make enough of these new blood cells for the person's body to continue to work normally. So if it does have a very high death rate, it's about 70% do die within 1 year if it's untreated. However, it does go up to the overall 5-year survival rate is about 80%. So this can be caused by things like autoimmune disease, chemotherapy that destroys the bone marrow, other toxins that also destroy the stem cells in the bone marrow. Signs and symptoms are any of the signs and symptoms that you can think of when a patient has low red blood cells. So things like being pale, fatigued, things that go along with low white blood cells, so prone to illness. And then things that go along with low platelets, things like bruising and bleeding, petechiae. Testing wise, we can do a CBC with differential to see what the different levels of these different blood elements are. And we can also do a bone marrow aspiration that will basically confirm aplastic anemia. Intervention wise, the patient is probably going to need blood transfusions to replace whichever blood elements are low. Also infection prevention, so they may be on neutropenic precautions, which we'll talk more about later. They may need a bone marrow transplant eventually. Also a balanced diet to help with healing of injuries and also preventing infection. There are specific immunotherapeutic agents that can be used. And then there's also other specific medications that can help the body make new blood cells. The next hematological disorder is hemophilia. So hemophilia commonly is a deficiency of factor VIII. There are a couple different types of this, types A and B, but we're just going to talk about hemophilia in a broad sense. So factor VIII is one of the clotting factors in the clotting cascade. So if the person is missing this specific factor, then the clotting cascade cannot be completed and a clot is unable to form as normal. This is X-linked recessive, so it mainly affects males. Females are usually termed as carriers and either don't have symptoms or have very, very mild symptoms. But the symptoms of it is bleeding. So any type of bleeding like nosebleeds, blood in the urine, blood in the stool, bruising, petechiae, large hematomas under the skin. They can even have bleeding in the areas around their joints. Often there's no bleeding seen in the first year of life. Commonly the first injury where the parent, for example, may see bleeding is in the gums. So when a tooth is starting to break through, could be then, or just the child gets an injury to their gums. But until the child starts to crawl or walk and then starts to fall down, we may not see as many instances as bleeding in an infant. Testing for this, if we test the PTT, which is partial thromboplastin time, it would be prolonged, for example, longer than 35 seconds. We could also test the clotting factor levels, and they would, of course, be decreased. Interventions, thankfully, we can give the child factor VIII. This can be prescribed. It's commonly given by IV push, but it could be slower, like an IV infusion. There are also newer forms where it can be injected at home. Sometimes also DDAVP, which is synthetic vasopressin, can be prescribed. In mild cases, this has been shown to increase factor VIII. They could also have corticosteroids prescribed, especially if they do have bleeding in the joint areas. We want to educate them to avoid aspirin because that interferes with platelet function. Injury prevention to try to prevent any sort of bleeding. Other things like using a soft toothbrush, and we recommend wearing a medical alert bracelet, so if something does happen, then emergency personnel will know that the child does have hemophilia. Lead poisoning can happen when the child comes into contact with materials that contain lead and either ingests it or inhales it. Children with iron deficiency anemia also absorb lead more readily. The American Academy of Pediatrics recommends screening all children for lead poisoning no later than 12 months of age, and then also yearly after if they are at risk for it. So places where lead can be found, most commonly is in lead-based paint, which is no longer made, but can still be found in places like older homes or older apartment buildings or things like that. Also other things related to that, caulk, plaster, soil can be contaminated with lead. The water can be contaminated with lead, especially if they have lead pipes. Cigarette ashes and smoke, exhaust from cars, old colored newsprint, like newspapers from a long time ago, not current newspapers, unglazed pottery, railings outside. Signs and symptoms can be sort of nonspecific and a little vague. Things like abdominal pain, vomiting, constipation, headache, not wanting to eat, being lethargic, and then other central nervous system signs like hyperactivity, impulsiveness, irritability, and delayed development. Testing for this, we can just test for blood lead level. We can also test for lead in the urine. We can also check hemoglobin and CBC. Interventions, the main thing we want to do is prevent exposure to lead. So educating parents about older homes that can be sources of contamination. And then also if the child is found to have lead poisoning, the main treatment for that is chelation therapy, where basically the child is injected with a certain medication that basically binds to the lead, and then they can excrete it out of their body. Also, removing the child from whatever location they're in that lead may be, or vice versa, removing lead from the location that the child is in. An immunological disorder is one where there's a dysfunction with the immune system for whatever reason. The only immunological disorder we're going to talk about is acquired immunodeficiency syndrome, or AIDS, which develops from HIV infection. So when we're talking about pediatrics, it's most commonly transmitted from mother to child in utero when the mother has HIV. Older children can be at risk for transmitting it through unprotected sex or IV drug use, but a little less common with pediatrics. The HIV virus infects specific T lymphocyte cells, which eventually develops into AIDS. The HIV virus is also found in breast milk. So the mother that's HIV positive cannot breastfeed. Signs and symptoms are swollen lymph nodes, mucocutaneous eruptions, which is this top picture on your slide. So basically like dermal ulcers in the skin, and can also be inside the mouth. They can have failure to thrive and delayed development, hepatosplenomegaly. They can be at risk for oral thrush, parotitis, which is basically inflammation of the parotid gland, which is that bottom picture, chronic diarrhea. Basically, they are at risk for catching any sort of infectious disease that they are exposed to, since HIV does infect these specific T lymphocyte cells and diminishes their immune system. Testing for HIV, we can perform an HIV PCR, which will show us if there's the presence of any antibodies to HIV. There's also an HIV antibody assay, which is similar. It's also called the Western blot, usually reserved for children over 18 months of age. And then there's, of course, the rapid HIV oral swab that can also be used. It is recommended that infants be tested at birth if they are at high risk for HIV infection. Basically, if the infant was born to a mother that has HIV who didn't have prenatal care or who was not taking prenatal antiretroviral therapy medications. Interventions for HIV and AIDS, we want to monitor and prevent any sort of opportunistic infections. So we want to look out for any sort of signs of infection. So just a couple of examples: fever, cough, altered level of consciousness, basically any sort of infection that anyone can catch. We want to be looking out for that. Of course, they can be prescribed antiretroviral therapy. You do not need to know any of the names of any of them. We want to recommend that they stay up to date on their immunizations so that we can prevent them from catching any infections. A high-calorie, nutrient-dense diet to promote growth and development. Oncologic disorders are a group of disorders with uncontrolled growth and spread of abnormal cells, which we usually call cancer. Also, sometimes you may see the word neoplasm, which is basically a fancy word for tumor. So a tumor can, of course, be benign, which is non-cancerous, or malignant, which is cancerous. For our sake, for our test purposes, we're going to be talking about a neoplasm as a cancer-causing tumor. A couple of examples of cancer in children that some of them we'll talk more about. One is a neuroblastoma that's more common in infancy and early childhood. This one is a cancer that develops from immature nerve cells, which are found in several different areas of the body, commonly actually in and around the adrenal glands. Another one is retinoblastoma, which is the bottom picture of that child's eyes, basically cancer of the retina. So you may not see the red reflex in the eye when you're assessing a child if they have a retinoblastoma. Wilms tumor, we will talk more about in a moment. Common cancers for adolescents: Hodgkin's lymphoma, which is a cancer that affects the lymphatic system, which we'll talk more about. And another is osteosarcoma, which is basically bone cancer. So this top picture where there's uncontrolled growths in the bone. There are many, many different types of cancer, and we're only going to be talking about a few of them. So when we're talking about neoplasms, again, we're going to be talking basically about a cancerous tumor. So this slide is basically a sort of broad, detailed information just on cancerous tumors. So it could be a variety of different things, but this is sort of like broad details about them in general. So signs and symptoms: the child could have pain that is directly associated with the tumor. Say if they have a tumor in their abdomen and when you palpate it, it causes them pain, or it could be radiating pain. So is it affecting nerve receptors from the actual tumor? Also things like weakness, weight loss, not wanting to eat, blood and urine, blood and stool, and anemia. Also, testing wise, we can do many different tests. So we can do a CBC, including an ANC, which is absolute neutrophil count. So we'll talk more about that on the next slide. Also, we could do an LP, which is a lumbar puncture. So the lumbar puncture is going to be directly testing the cerebral spinal fluid, which is going to tell us, is there any central nervous system involvement? So is there any cancer like in the brain or the spinal cord? We can also do a variety of different scans. such as a CT scan, an MRI, ultrasound, PET scan, all to visualize the tumor. Could do a biopsy of the tumor to see what it is. Is it benign? Is it malignant? Bone marrow aspiration if we believe that the cancer is affecting the bone marrow, and then exploratory surgery. Interventions, radiation therapy and chemotherapy could be prescribed, which we will talk more about, and also a bone marrow transplant. Meds to prevent nausea and vomiting. Commonly, the therapies that are prescribed, such as radiation therapy and chemotherapy, can cause intense nausea and vomiting and anorexia. So, meds to prevent that, and of course, pain medication as well. Since they may or may not want to eat very much, we want to make sure that the nutrition that they are eating is high calorie and nutrient dense. We also want to prevent infections. Again, since therapies like radiation and chemotherapy can depress the person's immune system, they are at high risk for infection. So we want to monitor for different signs of infections and try to prevent them. There can be a couple oncology emergencies. So one of them is tumor lysis syndrome. So tumor lysis syndrome is basically where, say, the child has gotten radiation therapy and the tumor is destroyed. So the tumor being destroyed is, of course, a great thing, but when it is destroyed, the tumor itself can release a bunch of different materials, mainly things like electrolytes. So these tumor cells can release a lot of potassium, calcium, phosphates, uric acid. So as we know, if things like your potassium and calcium get really high, it can cause a lot of problems. So things like seizures, dysrhythmias, intense muscle cramps, nausea and vomiting, kidney problems, altered level of consciousness. So something to look out for if the patient is getting something like radiation therapy or chemotherapy. Septic shock, which is basically going to be from overwhelming infection. So did the person, since their immune system is depressed, catch some sort of infection and become septic and then go into shock from that? Increased intracranial pressure, going to be due to something that's taking up space in the central nervous system. So for example, a brain tumor that's occupying space in the brain and is putting extra pressure inside the cranium. ANC, or absolute neutrophil count, measures the different types of white blood cells in the body. So there is a calculation on here how to calculate it. You do not need to know how to calculate it. What you do need to know is that a lower ANC indicates vulnerability to infection. So if you can imagine, the person has a lower amount of white blood cells, which will end up with a lower ANC. So basically, they're more vulnerable to catching an infection. Usually, if a person's ANC comes back as less than 500, that means they are severely neutropenic, and that is when we would initiate neutropenic precautions. Leukemia is a group of malignant diseases of the bone marrow and lymphatic system. So what happens is the bone marrow that is affected by this overproduces white blood cells, which doesn't sound like a bad thing. However, these white blood cells that the bone marrow is making are abnormal and immature. So they don't function properly, and they basically compete with other cells. So since they are competing with other cells, normal white blood cell count is actually low, and usually the other blood cell counts are low as well. So like RBCs and platelets are going to be low as well. So if you're looking at this little drawing of the slide of blood, the one on the right is leukemia, and you can see that there's these
large white blood cells, and those are basically going to be abnormal or immature and not be functioning properly. And you can see they're taking up all this space, so there is less platelets and red blood cells. Leukemia represents almost 30% of all childhood cancers, so it is the most common form of pediatric cancer. Signs and symptoms of this are anything that's going to go with anemia, neutropenia, and thrombocytopenia. So for anemia, they may be weak, pale, tired, short of breath. They may have a cough. They may be wheezing. They may be in respiratory distress. If they are neutropenic, they may be prone to infection and have delayed wound healing. If they're thrombocytopenic, they have low platelets, so bruising, petechiae, blood and urine, nosebleeds, blood and stool. They may be on bleeding precautions, which is similar to what we've talked about before, avoiding injections, using a soft toothbrush, no straining, so they may be prescribed stool softeners. They may have an enlarged spleen and liver because of this overproduction of these blood cells and enlarged firm lymph nodes. Testing for this, we can directly test the bone marrow with bone marrow aspiration for a positive diagnosis of these abnormal cells. We can do a CBC, and we can do different scans to see is there any metastasis of disease. Intervention-wise, they could need blood products transfused, depending on what they are low on. Chemotherapy could be ordered to suppress production of these abnormal cells. Of course, we want to prevent infection for these children, and they may be on neutropenic precautions if their ANC is less than 500. So no flowers or plants, no sharing a room. Everyone needs to wear a mask around them. If a bone marrow aspiration is ordered, the RN will not be doing it, but they will be assisting a provider. So the RN can apply an anesthetic cream, such as EMLA, whatever is ordered, over whatever site the provider is going to use 45 minutes prior to the procedure to help numb the area. This is a quite painful procedure. The RN can also administer conscious sedation per orders if they are checked off and able to do so. So again, it's very painful, and especially with a child, we want them to stay still during this, so they may be under conscious sedation. The most common site is the iliac crest, which is pictured in this drawing. So we would position the child laterally on their side. The tibia can also be used. After the procedure, we're going to hold pressure on the site for at least 5 to 10 minutes, even longer if the child does have thrombocytopenia. We want to monitor vitals for any bleeding after the procedure, and of course monitor for infection at the site. Lymphomas are cancers that affect the immune system. There are several different types of lymphomas, but we're going to talk about the two major types, which is Hodgkin's and non-Hodgkin's lymphoma. So Hodgkin's lymphoma is the lesser of the two. It just involves one single lymph node and contains these special cells called Rein-Sternberg cells. So this one, there's no spreading of the cancer to different lymph nodes. It just affects one. So this one is, there's a possible cure through removing the affected lymph node and chemo and radiation. Non-Hodgkin's lymphoma is the one that is a little worse. So this one affects the peripheral lymph nodes, and it easily spreads to other lymph nodes and other tissues throughout the body. It's the way I remember it is non-Hodgkin's, not good. So that one is the one that is not curable. On assessment, you may see, of course, enlarged lymph nodes. For the non-Hodgkin's lymphoma, depending on where the lymph nodes are that are affected. They could be so large that they obstruct the airway, that they obstruct the intestines. If they are in the jaw or the face, they could cause cranial nerve palsies in the face. Or if they're near the spinal cord, they could cause spinal paralysis. And then other symptoms like weight loss, fever, abdominal pain, nausea, vomiting, itching, night sweats. Testing, we can do a CBC. We can do different scans to see has anything metastasized, or if it's non-Hodgkin's, where are these affected lymph nodes at in the body. We can also do things like a lumbar puncture to, again, identify any metastatic disease. Interventions, we can remove the affected lymph nodes. They could have chemotherapy ordered, radiation ordered, immunotherapy, which basically targets specific antibodies on the surface of these lymphoma cells. And then, of course, we want to prevent infection because they are going to be at high risk for infection. This can lead to sterility, more so the interventions. So we could recommend something like sperm or egg banking. Brain tumors can arise from any cell within the cranium, and they're classified by their location of origin. Neuroblastoma is the most common type of brain tumor. It's the one that I talked about earlier that originates from embryonic neural crest cells. It is also found on top of the kidneys, but of course can be found in the brain as well. So we're just going to be talking though about brain tumors in general. So signs and symptoms of a brain tumor. They could have an increased head circumference, and this is of course only going to be for an infant whose sutures are not yet fused. Otherwise, their head, once their skull and their sutures are fused together, their head circumference can't really get much bigger. So this is for babies, but an increased head circumference can be a sign of increased intracranial pressure. They could also have a headache, a bulging fontanelle, again if they're an infant, nausea and vomiting, pupils that are either sluggish or dilated, weak, unequal hand grips. Testing wise, we can do scans to visualize the tumor in the cranium, MRIs, CT, PET scans, and then electroencephalograms to view the electrical activity in the brain. Intervention-wise, they could have chemotherapy. In the meantime, we want to monitor for things like seizures. Are they doing any posturing like the decorticate or decerebrate posturing? Of course, monitoring their vitals and doing other neuroassessment type things like assessing pupils and level of consciousness. If they do have surgery to remove the tumor, after the surgery, we want to keep them in semi-Fowler's position to help decrease ICP. So we don't want all of their cerebral spinal fluid flowing up into their brain and causing an increased pressure. So basically, we want them to be sitting up a little bit. We, of course, want to avoid Trendelenburg. We also want to avoid anything else that could increase pressure in their head. So things like vomiting, crying, sneezing, coughing. We want to decrease those things if possible. Wilms tumor is one that actually originates in fetal development. So basically the child is born with this tumor and we just don't know at that time. And then it's typically found on the kidneys around age 3 or 4. Parents usually report finding a bump around their waistband area or diaper area during, say, bath time. So basically, this tumor is on the kidneys. It can be on one or both of the kidneys. Signs and symptoms, there is usually a lump in the abdomen or waistband area. The patient could report pain from the lump. Since this tumor is on the kidney, it can affect the renin-angiotensin system, which can cause increased blood pressure. They may have a fever for no identified reason, and this may be associated with congenital anomalies, like a syndrome. So, because of that, chromosomes could be ordered, also scans to visualize the tumor itself, other things like a CBC, a liver panel, renal function panel, and urinalysis, since it is on the kidneys. Intervention wise, this one's a little bit different because one of the main interventions is basically do not touch the tumor. So while we always tell you to palpate for masses, this one we actually don't want to palpate it because palpating the tumor site can cause metastasis, which we obviously do not want. So we want the child to also not mess with this lump. We want them to wear loose clothing around their abdomen and waistband area. We also want to frequently assess their blood pressure. Manual blood pressures may be ordered. Assess their intake and output since it's on the kidney. They may be prescribed chemotherapy. And typically, of course, there is surgery that is ordered to remove the tumor. So this cancer is somewhat easily curable, although there is a chance that it can recur again. So one of the interventions we have been talking about is a hematopoietic stem cell transplant, also just called a stem cell transplant or sometimes a bone marrow transplant. So what this is basically a process of destroying the person's defective bone marrow and replacing it with new bone marrow or new stem cells. So this can be done with, as you can see, all of these different types of cancer that's listed in this box on your screen, but also for other disorders like sickle cell anemia and other immunodeficiency disorders. So basically what happens is the person is given a lethal dose of chemotherapy. It's termed lethal because basically if we didn't resupply them with new stem cells or new bone marrow, then they would die. So basically we are totally destroying all of their bone marrow that they have that is not functioning properly. So basically we want to get rid of all of that. So when we're giving them this very high dose of chemo, it's also going to put them at very high risk for infection and death. So this isn't something that's just done lightly. Sometimes it's more of like a last chance type thing. But we can get these stem cells sometimes from the own patient themselves through a peripheral stem cell transplant, where basically it's sort of like giving blood and they can collect the stem cells from the blood with a special machine. Also, we can take bone marrow from a donor or even from the umbilical cord. And in these instances, of course, it has to be matched, just like with organ donation. So intervention wise, it will be ordered an IV transfusion of these stem cells from whatever place they're coming from, the bone marrow, the blood, or the umbilical cord. To resupply them with these stem cells so that they then have disease-free bone marrow to make their different blood products in the correct way. But again, since they are getting this lethal dose of chemotherapy, they will be on protective precautions, also called neutropenic precautions. So basically, we want to keep everything clean. They're probably going to have some sort of central line that we want to make sure is being kept clean as well. No flowers or plants. Everyone's wearing a mask. Or keeping them away from, say, siblings that may be sick or anyone that may be sick. Just a review on blood administration. So, of course, before we give blood, we need to verify the order, make sure that we obtain consent from the patient or their parent in this instance, make sure that we have a PIV in place, it's just an 18 or a 20 gauge, um, making sure that we determine has the patient had a previous transfusion reaction. And then once we obtain the actual blood product, we need to administer it within 30 minutes of receiving it. Otherwise, if we can't within that time, we need to send it back. And then we need to check basically everything that's on the outside of the blood product bag. So, of course, the patient's name, date of birth, the ABO group, the RH type, their blood band ID number, the expiration date, basically everything that's on it we need to check. Depending on your facility, you may also be scanning the blood. We don't want to warm the blood unless that is actually ordered and there are specific blood warming machines. And we should be infusing each unit over 2 to 4 hours, but no longer than 4 hours. Radiation therapy is another intervention that we've been talking about. So the goal of radiation therapy is to destroy tumor cells and then allow normal cells to regrow and repopulate their surrounding tissues, depending on what area of the body that we are talking about. So there's two different main types of radiation, external and internal radiation. So external radiation basically comes from a machine that's outside of the body. So you can think of it like this machine is like casting this ray of light on this person to destroy this tumor. Whereas internal radiation, there's something implanted inside the body that's going to emit the radiation from it to destroy the tumor cells. So there are, as you can see on this slide, many side effects to radiation therapy. Specifically to external radiation is the first bullet point on here. So same as if you think as if like a ray of sunshine is beating down directly on a person's body, they could have things like skin redness, dermal ulcerations, and hair loss. And then all of these other side effects that are listed here. So things like headache, swelling, attention problems, dry eyes, cataracts, retinopathy, sclera melting, heart problems like cardiomyopathy, pulmonary fibrosis, esophagitis, being nauseous, vomiting, diarrhea, not wanting to eat, not being able to swallow, small bowel obstruction, bladder problems like bladder cystitis, nephritis. It could also lead to sterility or not having a period. Could also lead to myelosuppression, which is basically when bone marrow activity is decreased. So then the person can be anemic or neutropenic or thrombocytopenic. Slow bone growth in children, and then other more vague symptoms like being tired, lethargic, and an increased need for sleep. Chemotherapy is one of the other interventions we've been talking about. So chemotherapy also is going to destroy and kill cancer cells, shrink tumors, or destroy the tumor totally. So chemotherapy is typically given through IV, but there are also oral pills as well. With chemotherapy, the drugs are not specific necessarily to the type of cancer cells. So while the chemotherapy is basically destroying these cancer cells, they can also be destroying or negatively impacting other healthy tissues. So again, there can be a lot of side effects, which are similar to radiation: hair loss, mouth sores, nausea, fatigue, not wanting to eat, vomiting, things like that. It's often administered in cycles, so the person may be getting a round of chemotherapy, and then basically they have a break from it for a period of time, and then they will have another round of chemotherapy. You do have to be chemo certified in order to give chemotherapy. You do have to double check it with another nurse, sort of like giving blood and checking all of the info on the chemotherapy, sort of like giving blood, checking the patient with 2 forms of ID, and sort of like all of the rights of medication administration. The main thing then after giving it is monitoring for all of the potential side effects.